joining us for what I'm sure will be a really exciting session. So my name is Nick Macklon. I'm a medical director at London Women's Clinic. I'm an editor of RBMO. And RBMO, as you all know, is organizing this 6th of our seminars with our colleagues at I3. And we're delighted to be with you this evening. Many of you will know the RBMO journal. It's one of the leading international journals in reproductive medicine. And I think it's perhaps particularly known for its founder, Bob Edwards, of course, but also the tradition it's had to bring sort of new and innovative ideas to our field and set discussions going. And I think continuing in that tradition, a couple of years ago, we set up a new section called Reproduction, Technology and Society to provide a platform for discussion and the presentation of rigorous academic work in the field of the impacts of reproductive technologies on people and society in a broader sense than is perhaps normally the case for journals in our field. And it's been really delightful actually working with Jacky and others to see this taking off and becoming such an important and useful platform for our colleagues in the field. And therefore, we're very happy tonight to be talking about RTS, the RTS section. And what we're going to be doing this evening is addressing a very big question. We need to talk about apps. Apps are everywhere, and they are growing in huge numbers in our field in reproductive medicine, both from the professional side to help us practice our work, but also, of course, for patients. And it's becoming perhaps quite a difficult area for them to be able to navigate, given the profuse number that's growing. So Jacky and I are delighted this evening to be able to welcome 4 speakers who have all made original contributions to this field. And we will be discussing their work that's all been published in RBMO over the last year. It's been selected from the RBMO as being particularly important papers. And we're delighted that they're able to join us. As I said at the beginning, it's very important that you participate. We're going to be having a discussion after the presentations, and there will be a short time for questions after each presentation. And I would ask you to use, as I said, the Q&A button to write your question, say who you are. If it's directed at a particular individual, please say so. So I'd like to move on next to introducing my co-chair this evening, who I think many of you will know. Jacky Boivin is Professor of Health Psychology at the University of Cardiff and is also a practicing clinical psychologist in the area. And she has made major contributions to this area over a whole number of years, researching in the psychology of reproduction, of the experience of health and how we can improve that, but also developing tools which have become really important in how we assess quality of life for people who are facing fertility problems and treatments. The Fertiqual is just one example. So it's a great pleasure to have Jacky, who's also section editor in RTS, to be co-chairing this evening. And without any further ado, it's my pleasure to hand over to Jacky to move things forward.
Thanks very much, Nick. It's a pleasure to be here, as you said, to talk about these important papers on various different apps that are used now for people trying to conceive at different stages of trying to conceive, or even not trying to conceive, to be honest, to monitoring menstrual cycles, to preconception care, to fertility education, and so on. I think one of the important topics or the streams that we're going to have tonight will relate to the use of those technologies. So it'll be really interesting if people in the audience can give us ideas of the apps, perhaps that they use in clinics, or how they would like to use apps, or you know, their experiences of it, to cue us in the Q&A section. I think that'll be really interesting. Thanks to Nick for the kind introduction. Of course, everyone also knows Nick. He's as he said, he's now the group medical director of London Women's Clinic in the UK, and you're also professor at Zealand University Hospital in Denmark, and he's made a fantastic contribution to RBMO over the years, and also in setting up this section on reproduction, technology, and society. And of course, he is a fantastic researcher, amazing bio, which you can read, of course, on the i3 website. So I think we're kind of ready to start. What do you think, Nick? Shall we?
Yeah, I think we are, yes.
Okay, so it's my pleasure to introduce Alice Domar. And it's a great pleasure to introduce Ali because we have known each other for donkey's years. I think the first time I met Ali was in 1987, and I was so stressed.
We were both 12.
I was so stressed about meeting the person who knew everything about stress. So it was quite good. Unfortunately, we were on the opposite side of the stress question. Does stress cause fertility? But over the years, we've had quite a nice relationship and come together from time to time on research projects and so on, inclusive the development of interventions for patients. Ali's a health psychologist. Of course, her big area of research is mind-body medicine. That's what she's known for in women's health issues. She is really the person who knows everything about stress and fertility and stress and infertility. And she has most of her research has a cognitive behavioral side to it. So she was a pioneer in that, of course, in the area. Patient support, access to care, patient retention. First dropout paper, I think, in psychology, you were the lead author on. So it's fantastic, really, to have you here today. She's recently moved. She's now chief, and I love this title, Chief Compassion Officer at the Inception group of clinics. And I think it's going to be brilliant to hear her talk today. Now, also here today is Alison Meyers, who was the first author on the work that Ali's going to present. This is work they did together collaboratively, of course. She's studying the field of reproductive endocrinology and infertility and how infertility impacts mental, emotional, and psychological health. She was at Middleburg College Neuroscience 2021, in 2021 when she did this work with Ali. So Alison Meyers is going to join us in the Q&A to address any questions you might have for the panel at the time. So Ali, please tell us everything.
Well, thanks so much, Jacky. It's always funny when you and I introduce each other because we complement each other in so many different ways, even though we started at opposite ends of the spectrum. And yes, you and I have been co-investigators on studies together, which is amazing. It means that Coke and Pepsi can like each other. So, I'm going to start sharing my screen. And, I think it's just, it's a little confusing because as everyone knows that I'm Ali. And Alison Meyers was my intern in the summer of 2020. And she also goes by Ali. And so the physicians that we were working with termed us Ali 1.0, that's me, and she's Ali 2.0. And everyone now refers to me as Ali 1.0. So it takes a little bit of the confusion away. But when we do Q&A, if you want to ask me a question, you're going to have to say Ali 1.0 and for her Ali 2.0. But anyway, so, I was asked to write this paper, this review a couple of years ago, and Ali 2.0 really took the lead on this. And so I want to present some of the data that we presented in the publication that was published in RBMO. And unfortunately, there we go. So, I do have a couple of disclosures. I'm the co-owner of two apps, Ferticom and Fertistrong. I'm a consultant to Rescripted, and as I said, this review is based upon the publication with the same title, where Ali 2.0 was first author. So I want to give a little background in terms of why do we need apps for women and men going through infertility? Why do we need apps? I mean, I understand why we need apps for some of the physiological things like when you're going to ovulate and, telling patients when they should take their meds. But why do we need apps for the psychological impact of infertility? And so I want to give a little bit of a background. It's really only come to the forefront of our knowledge base in the last maybe 10 or 15 years that men and women who are experiencing infertility, whether or not they're in treatment, experience very high levels of psychological symptoms, most especially anxiety and depression. And in general, the longer the individual or the couple has been trying to get pregnant, the greater the risk of psychological symptoms. And in general, these are not people who had a history of mental illness. These are people, for the most part, who are psychologically healthy, attempted conception, were not successful, and developed negative psychological symptoms as a result of their infertility. So I think one of the best studies to date was done by my colleague, Lori Pash at University of California, San Francisco. And she evaluated actually men and women, but I'm presenting the data now on women. So 352 women who were seeking treatment for infertility, and over half scored in the clinical range for depression, and 3/4 scored in the clinical range for anxiety. And these are absolutely astonishing numbers. It means that for those of you who treat infertility patients, you then have to assume that more than half of your patients are depressed and more than 3/4 of your patients are anxious. Sort of tragically, of the ones who had symptoms, only about 1/5 of them remember being offered mental health support, and only 27% of the whole group had ever seen a mental health professional. And this is at a clinic which actually has a really good offering of mental health services for their patients. So what we can say from this study is our patients are really suffering psychologically, and yet most of them are not being offered or are not taking advantage of the psychological services offered on site. So if you look at some of the global data and publications, there are estimates that anywhere from 1/4 to 60% of women going through infertility report symptoms of depression. And I remember a number of years ago, I was giving a talk to a clinic about my body and depression, and one of the nurses asked me if I ever worried about suicide. And I said, no, actually, I wouldn't worry about suicide in our patients because our patients are trying to get pregnant, which means they're looking towards the future and they have plans and they feel hopeful. And the nurse said, yeah, well, we just had a suicide. And so I actually looked at, and there've only been a couple of studies. This is a large Danish study. One large did say that women who did not have a child after their eval were more than twice as likely to attempt or commit suicide than women who had a baby. And in another study, they found that almost 10% of surveyed women had reported suicidal ideation or even an attempt. And there's another study that's sort of circulating that someone mentioned to me about a week ago that said in some populations, upwards of half of all women going through infertility admit that they have thought about suicide. And so when we're talking about the distress in our patient population, we're not talking about people who are slightly unhappy. We are talking about people who are often clinically depressed, clinically anxious, and even getting to the point where they think about or risk, in fact, hurting themselves. So despite the prevalence of these symptoms, only a very small number of our patients or women who go through infertility report any sort of psychological support, and estimates are anywhere from 9 to 21%. And this is just extraordinary that we're working with patients who are coming into the clinic a lot. The majority of them are anxious and or depressed, and yet most of them are not asking for or getting any kind of support. And we just published a study actually in RBMO a year ago where we did a global study. So there was 9 countries around the world. We included almost 2,000 women and men experiencing infertility. And it was so it wasn't 2,000 infertile men and their partners. It was half of it were people, either women or men, who had infertility, and half were the partners, either women or men, of the person with a diagnosis. And what we found was that participants who reported getting some kind of offer for supportive and or mental health services were almost twice as likely to move on to treatment. And that's just an amazing number. And I've been giving a lot of talks lately around the world saying, hey, look, it looks like from this data that if you can offer patients support, if you can provide services to make them or help them get emotionally healthier, they are far more likely to move on to treatment and thus potentially have a baby than women who do not get those kinds of support. So another problem about psychological distress is that individuals who are distressed are far more likely to drop out of treatment. And insured patients, the emotional burden of treatment is the #1 reason why patients drop out prior to achieving a pregnancy. And again, by the time patients get into treatment, if they drop out, they are extremely unlikely to have a spontaneous pregnancy. So Jacky mentioned a study that she and I did together a number of years ago. We recruited 166 women who were about to start their first IVF cycle. We randomized half of them who received a stress management packet in the mail, and half got nothing. And the women who got the packet in the mail experienced a 67% reduction in dropout behavior. And that's pretty extraordinary because we didn't even ask them if they used the packet. We just mailed them a packet. And they were 67% less likely to drop out compared to the routine care control group. And so this shows that even a small intervention, a small psychological intervention, can have a huge impact on patient behavior. So what we do know is, our patients need support, but they need support and counseling and all these things, but it has to be convenient, it has to be confidential, it has to be effective, and it has to be data supported. I was just talking to someone earlier today who come up with a new intervention, and I'm like, we need data. You need to be able to say, yes, this is an effective intervention. But when you talk to patients, they say, yes, I'm upset, I'm anxious, I'm depressed, but they don't know how to access resources. They worry about the cost. They worry about how to schedule it. They don't think they have time for it. They worry about confidentiality. They're afraid that their physician will dismiss them from treatment because they're distressed, and they worry about travel. A lot of our patients work full time. So, mobile apps seem to be the answer. And there are lots of mobile apps and online programs that are being offered to and marketed to and very aggressively pitched to individuals and couples who experience infertility. But only a very small minority, and this is what my talk obviously is on, the emotional aspects of infertility and its treatment. But of all these apps, only one app and one online program are actually based on a randomized controlled trial. Both were very small pilots, and very few of the others have solid data to support their efficacy. But there are a few randomized controlled trials in progress currently. So if you ask me to give this talk in a year, I suspect we'll have very, very different and better data to present. So FertiStrong is an app for men that I helped create. It's designed to target men who are experiencing stress, whether or not that man is the patient or the partner of the patient. And basically, we did it with 2 experts who counsel men, Bill Peacock and Janet Tackefman. And we came up with the 50 situations where the most common triggers for men in their family building journey. About half are strategies for the man to use for himself, and half are suggestions on what he can do to better support his partner. So we actually had a month between when the app was built and when the app was being released. And so we did a little tiny randomized controlled trial. We recruited 38 men who were randomized to receive the app on their phone. Half got the app, half were not. So it was 19 and 19. And they all completed psychological questionnaires prior to and following the 28-day study period. And even though we had a very small sample size, it's tough to get results when you have 19 people in each group. Actually, a number of the results were statistically significant. But in all categories, the men who received the app, all of them reported less distress than the control group. The control group reported a significantly greater increase in their stress level than the intervention group. And so everything we looked at, the men who got the intervention did better than the control group. And as I said, a few of those numbers were statistically significant, even with such a small study size. MediAmo is another mobile app designed by, I know it's been helped bring to the table by Jacky Boivin. And this one is sort of a dual purpose. It provides both medical and psychological support. So it provides medication and drug management, usually during the first 2 weeks of the cycle. It offers mood monitoring, and then there's a component of coping support that has a focus on the PERSI, which is, helping patients positively endorse and to rethink their situation. And in fact, the PERSI was used in that dropout study. And the DBCI, which is basically distraction-based coping rather than cognitively based coping. And what they found when they offered the MediAmo app to women at a clinic in the UK is the women who used the app were almost twice as likely to return to care than the women who did not use the app. And so, yes, this was not a randomized controlled trial, but the results were very different between the women who used the app and the women who didn't use the app. And this was presented at ESHRI a few years ago. They've also recently published a study on the Meta-EMO where they collected data for 3 years, and about almost all the patients asked about the app or expressed interest in using it, and uptake was almost 80%. The patients did use the medication information more often than the emotional, but still 62% used the coping suggestions and the mood monitoring. But interestingly enough, there are big drop-offs in use after retrieval. And it's really odd to me because what we know, and in fact, is Jacky's data to show that patients' distress levels are their greatest between the waiting period between transfer and pregnancy test. And I would have actually expected that's when the app would have been used most often. But they are now doing an evaluation study to really assess and be able to present the efficacy of the Meta-EMO app. MoMaFer is another app designed to provide instruction on a mindfulness-based intervention for individuals. Mindfulness means to be in the moment. It's very effective and very popular with lots of other disease population. That we don't have data on the efficacy. A randomized controlled trial is currently being conducted on its efficacy. And so they're randomizing 60 men and women to either receive the app or be in a waitlist control group. And they're going to collect data at baseline, 6 weeks and 3 months. So again, I think in about a year, we're probably going to have some nice data as to the efficacy of the MoMaFer app. I was involved in this internet-based program. It was modeled after the 10-session live mind-body program that's been around for about 35 years. This was done by a graduate student at the University of Vermont. And she recruited 71 women who are at various stages of infertility. And they were either randomized to do this online single-person program or be a waitlist control. And the intervention patients reported significant decreases in pretty much every psychological symptom we assessed. Stress levels came down, social concerns came down, sexual issues came down. And the pregnancy rate in the intervention group was 53% compared to 20% of the control group. And so here we're showing that you could take a clinical program where people meet in person, and especially post-COVID now, we can show that doing an online internet-based program can be highly effective, not only at reducing psychological distress, but potentially increasing pregnancy rates. Ferticom is another app that I helped to design. It's very similar to FertiStrong, but it's for women. Again, cognitive behavioral skills. We came up with the 50 situations that cause the most distress, such as hearing a pregnancy announcement or getting a period or a negative beta. We now have a little over 26,000 users, and we did an early study on 292 women who stopped using the app. When we asked them, why did you stop using the app? Half of them, the most common reason, said, I was feeling less anxious and depressed. But to be honest, that's the only data we have right now at Ferticom. So in conclusion, I think it's obvious because of the very high stress levels that our patients report, we need more of this. Mobile and online applications are not being developed, researched, or effectively used by our community. We need more things to offer patients. We need them to be research-based. They need to be based on randomized controlled trials. There's a huge gap. And so not only are there not very many well-developed programs or apps, there's an even greater lack of research on their efficacy. And I think all of us need to do what we can to try to create, not just create new mobile or online programs, but prove that they're effective and then get them out there to all of our patients. Thank you.
Thanks very much, Ali, for this great talk and, for really helping us to understand why there's such a great need for these apps. Basically, I agree with you, there's a high need, but as you say, patients are either not accessing these, the right kind of care, or they're not being offered it. So, right. I just, before we go into the panel discussion at the end, I do have one question here around the issue of implementation for these apps. So we do have some apps that people have been developing. There's a bit of research on that, but we don't see them all that much in clinics. So, you know, I mean, I guess it's they're still small RCTs. The efficacy is not really well established. Can you tell us a little bit more about this gap between development and implementation?
I'm going to turf this to Ellie 2.0 because she's closer in age to our infertility patients. And I think she's going to have some really good insight because her generation has so much more familiarity with the technology. So Allie.
Thank you, Allie. So hi, everyone. I'm Alison. Professor Jacky introduced me, and I was so lucky to work with Dr. Domar 2 summers ago while I was a junior going into senior year of college. So that was fantastic. And I did get this opportunity to write this article and do this research. So regarding this question, which is a really important question, how do we actually get these apps out there as they're being developed? How do we get them actually implemented? So I guess one of the major things to kind of back up before implementation is, how do we know that these are good apps? So especially now, you can go to the App Store, you can go to the Google Play Store, and you have a million apps pop up for anything that you can type in. It's not, you know, a phase 1, phase 2, phase 3 clinical trial that these apps are going through. Some of them are going through to get onto this distribution system. Basically, anyone can produce an app and put it out there. So I guess the major thing, the first thing with implementation is, how do we know it's a good app? So there, and Allie did touch on this, Allie 1.0 did touch on this, is that we do need more data supporting these different apps. And then once they are developed, again, how do we implement them? So Allie pulled up some data from Lori Pash that only 27% of these patients are actually being offered any kind of mental health resource when they go to an infertility clinic. And that doesn't mean web-based or app-based or anything like that. That means anything in general. So I think that's kind of the first step, that there has to be knowledge at these clinics of these apps and these evidence-based apps before anyone is going to use them. Because I wouldn't, as a patient, I wouldn't think to just go on my app, my phone, and say, infertility treatment for mental health, or mental health treatment for infertility. That's just not something I would do. I need to be told that from a physician or someone who knows that, hey, this could actually benefit you, and this could help you decrease these psychological and emotional effects of infertility that you're facing that can be just as bad as actually going through fertility treatment along with it. So a major thing there is, I think that promotion from physician offices is a major step towards implementing these apps. And that can just be your doctor handing you a pamphlet after your first visit, something like that. And it could even be a preventative. As you go into the infertility office, or you go in for this treatment, you don't know if you're going to start developing all these emotional effects. They could hand you a pamphlet before you even walk out the door of your first appointment, just so you know it's there. And I think that's a major step in the implementation.
I think it's true. Patients are reassured, aren't they, when they get given that kind of support. I think this is going to be a topic we're going to go back to during the panel discussion. But what you're basically saying, at least at this stage, is we need to get the evidence. And once we have the evidence, make sure that the doctors and the clinical staff feel confident in recommending it. Okay, brilliant. So that gives us a little bit of a snippet, enough to go to our next talk. And then I think we're going to return to this topic of implementation, because I'm sure that it's going to affect all the other app users as well, I would think. So the next presentation is a recorded presentation, but hopefully our colleague, Dr. Eri Maeda from Japan, will join us at the end for the Q&A. She's recorded her presentation, as I just said. I'm just going to introduce her anyways. And the introduction is basically, she's a public health doctor for the Tokyo Metropolitan Government and she had her PhD in social medicine. So she's really a public health person from the University of Tokyo. She's now associate professor at the Department of Environmental Health Science and Public Health at Akita University Graduate School of Medicine in Japan. And her research, and I've had the privilege of working with Eri, is really addresses the broader public in terms of their infertility and their infertility needs and gaps, about preparation really for the experiences of fertility or infertility. So in their preparation of planning for parenthood, and then preparing for any possible pregnancy with or without medical assistance, if you will. She's also interested in reproductive epidemiology in a broader topic. So I think we can start the video now.
Well, thank you for inviting me to such an exciting event. My speed presentation is about the use of an online chatbot to promote fertility awareness. Providing fertility information through brochures improves fertility knowledge and changes intentions for childbearing, but it increases anxiety. Users respond favorably to tailored education approaches, but the costs are often too high. Chatbots are automatic conversation programs. In the example here, the user is chatting about the effects of smoking on fertility. Chatbots are increasingly used in health education, but not yet for fertility awareness. So our research question is, what are the effects of using a fertility education chatbot on knowledge, intentions to improve preconception behavior, and anxiety? We programmed the chatbot with scripts that provide customized responses to individual users' questions about reproductive life planning and counseling. To test the chatbot, we conducted 3-armed randomized control trial using an online social research panel. We recruited 927 women aged 20 to 34 years who hope to have more children in the future. Intervention group experienced fertility chatbot. Control group 1 received information through online document. And control group 2 received irrelevant information. We evaluated the effectiveness of the chatbot by asking the women to complete the Cardiff Fertility Knowledge Scale and State Trait Anxiety Inventory. We also asked about their intentions to optimize their behavior and any other relevant information they wanted to share. The results show significant knowledge gains in the intervention group and control group 1. Please see figure A. Post-test scores of the intervention group were higher than those of the control group 2, but lower than control group 1. As shown in figure B, the intervention group and control group 1 showed significantly stronger intention than control group 2 to optimize their fertility-related behavior. As shown in figure C, the post-test state anxiety score was significantly lower in the intervention group than compared to both control groups. Some technical limitations were also pointed out in the users' feedbacks. For example, some pointed out low comprehension of their words. Feedbacks included some pros and cons. Some said the chatbot was convenient, but the others said they felt impersonal. So here's the conclusion. Education using a chatbot improved fertility knowledge and intention to optimize fertility and preconception behaviors without increasing anxiety. Although the observed improvement in knowledge was small, the study suggests that new digital technology offers promising options for low-cost and accessible fertility health education. And now our chatbot is publicly available, although it is currently limited in Japanese. Please scan the QR code shown on the slide and give it a try. Thank you.
Eri's not with us, but hopefully if people have any burning questions, we'll be asking her those at the end in the panel.
Okay, so thank you to our speakers thus far for getting us off to a great start. It's been really good to see the questions coming in. What we want to do is try and keep the conversation going at this stage with the presentations, and going to have time afterwards where we'll try and address as many of the questions that are coming in as possible. So it's now my pleasure to introduce our next speaker on the speed presentations, and that's Bonnie Ng, who's from Southampton, University of Southampton, where she's an MRC Clinical Research Fellow in Obstetrics and Gynecology. Bonnie's got quite broad research interests. She's been interested in apps and developing preconceptional care models in reproductive failure. You might have seen her name associated with one of the papers that was being presented earlier. And beyond this, she's also doing some research in more basic science, looking at natural killer cells in the pre-implantation endometrium. So a broad perspective. And Bonnie published this paper a little while ago in RBMO. And we felt that it follows on actually very nicely from the previous talk, because it's addressing the same challenge, which is trying to encourage good behaviors, if we can call them that, in women and possibly men too, of course, who are facing fertility problems or recurrent miscarriage, where we believe that lifestyle issues are contributing to outcomes. So we know that, but what can we do about it, and what are the challenges? And we've already heard one route to that through chatbots, and Bonnie's going to tell us about her work looking at another approach. Bonnie.
Hello to everyone joining from across the globe. Thank you, Professor Macklon, for the kind introduction, and to RBMO for the invitation to speak at this live webinar series. I'm going to present to you the results from our RCT, which showed that a smartphone-based lifestyle coaching platform modifies behaviours in women with subfertility or recurrent miscarriage. Next slide, please. The impact of periconceptional lifestyle factors on fertility and pregnancy outcomes has been well described. Following on from the developmental origins of health and disease paradigm set out by Professor David Barker in the 1990s, numerous studies have shown that early in utero nutritional environment indeed programs embryo and fetal development. Various national and international clinical guidelines emphasize the importance of a healthy lifestyle when planning a pregnancy. Despite strong evidence to support the importance of healthy lifestyle and behaviours around conception, it is unclear how best we should support our patients, and changing their behaviours has proved to be challenging. Within reproductive medicine, the introduction of a smartphone-based lifestyle coaching application known as Smarter Pregnancy has proved to be successful in improving periconceptional behaviours in the general population and in couples who are undergoing IVF. The aim of this study was to assess the effectiveness of the Smarter Pregnancy lifestyle coaching platform in modifying periconceptional behaviours in women referred to subfertility or recurrent miscarriage clinic. A total of 440 women were recruited to this two-centre randomised control trial. The women were randomised into either the intervention arm or the control arm. All women were asked to complete a lifestyle questionnaire at baseline, 12 weeks and 24 weeks after randomisation. Those randomised to the intervention arm had a personalised lifestyle coaching programme, which included access to tailored advice and feedback on their lifestyle based on their responses in the follow-up questionnaires. Emails with feedback on progress, recommendations, tips, facts and recipes were sent to the participants to encourage them to change unhealthy habits and maintain healthy ones. Those randomized to the control arm were directed to the NHS website offering standard lifestyle advice for women planning a pregnancy, and these women did not receive any tailored feedback on their lifestyle behaviours. Regression analyses were used to compare composite dietary and lifestyle risk scores at 12 and 24 weeks after randomization. So what were our findings? So from the results, you can see firstly, there was no significant differences in the baseline lifestyle risk scores at the 95% confidence interval. On the right-hand side, we show the difference in risk scores between the intervention and control arms correcting for baseline. The horizontal dotted line shows no difference between the two arms. A negative value or values below the dotted line demonstrate a larger improvement in lifestyle in the intervention group compared to the control group. So women who received the coaching program demonstrated an improvement in lifestyle risk scores at both 12 and 24 weeks after randomization. And this is shown by values below the dotted line for the total risk score, fruit, vegetable, and folic acid intake. Next slide. And what is more interesting is that subgroup analysis showed that in women that were overweight, so those with a BMI of 25 or more, there was a significant reduction in smoking and alcohol intake risk scores in the intervention group. Although subgroup analysis by BMI and other lifestyle risk scores did not reach statistical significance. A secondary outcome measure was the odds of being pregnant at 24 weeks after randomization. In the intervention group compared to the control group, the odds of being pregnant was 2.86, and this was statistically significant at the 95% confidence interval level. Although we should note that the number of women achieving a pregnancy during the study was small. So in conclusion, we have shown that Smarter Pregnancy, an online access lifestyle coaching platform compared to standard NHS advice, is more effective in improving periconceptional behaviours. And it's particularly effective for women in the overweight category. It may represent an empowering and cost-effective means of delivering periconceptional advice to women with subfertility or recurrent miscarriage. Thank you for listening, and I'd be happy to take any questions.
Thank you very much, Bonnie, for taking us through that so quickly and clearly. So it is open for questions. I think while we're waiting for people to think, and we can come back to more questions later, of course. One of the questions that's been coming up actually through this evening has been people have been interested in apps, and those which seem to be shown in randomized controlled trials to be effective are causing interest amongst our audience tonight. And many of them are asking, where can we access these? Can you tell us a little bit about the Smarter Pregnancy app that you were testing? Is that still available? Is it something that's available internationally, or is it just, I think it was developed in the Netherlands. Is it just available to the Dutch audience?
So there have been several randomized control trials carried out, and it was developed first of all in the Netherlands by the Reproductive group. And they tested it within the general population and the couples undergoing IVF treatment. And they've shown it to be effective in that cohort of patients. So at the moment, it's sort of available for research purposes. It's been developed initially in the Netherlands, but also introduced within the UK for a research setting. I think it has huge potential to be rolled out to the wider population, given that there has been sort of several studies showing that it's effective for women who are planning a pregnancy, given that it's portable, easily accessible and low cost. Then it has a potential to reach a very large population and change behaviours and potentially clinical outcomes. At the moment, I don't think it's available to the general public, and there's ongoing sort of research looking into this before further implementation, wider implementation.
It's certainly a well-studied one. I think for people who are interested, let me just sort of make it clear that it's not something that either Bonnie or I are involved in, but I think if people are interested in looking at it, I think it is available to look at online under Smarter Pregnancy. At least that's my understanding. But you know, again, getting this into the hands of the population looks to be one of the challenges just now. But thank you very much, Bonnie.
Thank you.
And thanks for taking us through that. And I'm sure we'll be coming back to you later for the discussion. So we now go to the third of our shorter talks this evening, and it's a great pleasure to introduce Professor Joyce Harper. I'm sure all of you know her. She's extremely well-known, established figure in our field with very, very broad research interests, and been very influential in our field over many years, both as an academic, author, scientist, and indeed an educator more recently, particularly on fertility awareness. She's published extremely widely. Her career started as an embryologist, and then she moved into reproductive genetics and science, and she's now researching primarily on fertility education, femtech, which we're going to be learning about from her this evening, IVF add-ons, gamete donation, and the menopause. A very, very well-known, popular speaker, and we're delighted to have you here with us this evening, Joyce. Over to you.
Thank you very much. It says I can't start my video, so just wondered whether I've got my mic on, but it says unable to start video. I am here, so oh, here we go. Right, brilliant, thank you. So good, great to see everyone. So yes, real pleasure. Thanks RBM Online for allowing me to talk about this paper. Do fertility tracking apps offer women useful information about their fertile window? And this work was done by Roshana Ali, Zainab Gurton, and myself. So just some declarations affecting this particular lecture. I have been paid by a number of people to give lectures, and I'm going to talk about some work I did with the app Natural Cycles, and they also paid me for those studies. And I have written a book called Your Fertile Years about the menstrual cycle to the menopause, and I go into companies and teach them about various aspects of reproductive health, including the menstrual cycle. Next slide. Oh, sorry, the research question. To characterize mobile fertility tracking apps, to determine the use of such apps for women trying to conceive by identifying the fertile window. Next slide, please. Thank you. So we all know that the two key events of the menstrual cycle are period and ovulation. And for people trying to get pregnant, obviously ovulation is really key. Now with femtech, which is the use of technology to help women in various aspects of women's health, we have the period tracker apps and fertility apps that are hugely popular. And the period tracker apps, mainly they just look at dates. So they track the date of the period and they predict the next date of the next period, which is really useful information for women through their reproductive life course. But what I became aware of many years ago was that they are also, almost all of them predict the day of ovulation and tell women the day they ovulate. And this is through just looking at menstrual cycle dates using the historic textbook of we have a 28-day cycle and we ovulate on day 14. And the trouble is that many of these apps also come up under fertility apps. So a fertility app, in my view, ideally needs to measure a marker of ovulation. So if it's going to be an app which women are going to use to try and help them get pregnant, then we need accurate information about the day of ovulation. So they could be measuring their basal body temperature, their changes in cervical mucus, or do an LH urine test. So when I became aware of these apps, and especially the information about ovulation, I was also at that point writing my book, and I went back and read the original papers that classified our menstrual cycle as 28 days and ovulation on day 14. And these were studies that were done many years ago, and they were done on very small numbers of women. So now we have big data with these apps, and it's really great to be able to make use of this big data. So I went to Natural Cycles, which is an app that is mainly a contraception app, but it can be switched to a fertility app, and it is measuring ovulation using basal body temperature. And I was aware that they had millions of menstrual cycle data with period length, time between period, and also ovulation. So they have been a great team to work with, and we published our first paper together several years ago now. And we really rewrote the textbook, looking at over 600,000 menstrual cycles. The most important finding, there's many findings of the paper, but the most important was that overall ovulation was actually on day 16. It was actually 16.9, so nearer to day 17. And several other studies have shown very similar data. So these apps that are telling women when they ovulate on day 14 are really being inaccurate. So the methods for this paper was to audit apps that came up under fertility apps. So when you searched in the App Store, we looked at those that said, yes, fertility. And so we audited 90 of the apps. Next slide, please. So our results showed that 78% of the apps came up under health and fitness. They were mainly free, 76% were free. They obviously were mainly targeting females. 70% were what we call feminine apps. So we can see on the diagram on the right from the Atlantic, the awful pinkness of period apps. So they're very pink and very flowery, which I think in 2022 is not probably the right marketing way for this. 65% of the apps targeted age 12 and over, and 8% age 17 and over. And our recent survey that we've just had published on women's experience of using these apps, most start using the apps when they're teenagers. So our question for this paper was when the information that they're giving about when ovulation is. And so ideally, we would like to see these apps measuring a marker of ovulation, but unfortunately, the majority of the apps only looked at dates. So 54% looked at dates only 39% looked at dates and basal body temperature, 5% dates and mucus, and just 1% dates and luteinizing hormone. So this is really worrying that the majority of these apps, these fertility apps, are only looking at dates, which is an unreliable predictor of ovulation. Next slide, please. Next slide. Oh, thanks. So in conclusion, unfortunately, the apps were really heterogeneous. The unreliable calendar only apps were the most common. And the question is, are they useful for women that are trying to get pregnant to help them understand their fertile window? So the answer is no, if they're only looking at dates, but possibly yes, if they're measuring a marker of ovulation. So we looked at time to pregnancy with natural cycles, and we've published a paper on this, and the vast majority of women were pregnant. It was over 90% of the under 35s were pregnant within a year. And it was really good to see that information. On the right, you'll see our two most recent app papers. One complicated data paper using period tracker applications, the top 10 apps that are downloaded to look at different menstrual cycle information for different women. It's a brilliant paper, but it's quite difficult to explain it very quickly. And this second paper is our survey of women's experience of using period tracker apps, and we're just about to submit our second paper from there. So in conclusion, all the work that I'm doing now, as Nick was saying, is looking at how we can educate the public and health professionals about fertility awareness. So we have set up the International Fertility Education Initiative, and it's great that Jacky and Eri are on board with this as well. And we now come under the auspices of ESHRA. So watch this space for some more important work from this initiative. Thank you very much.
Well, we can't hear you.
I'll try again. I'm getting messages. Good. Can you hear me now? Yes. Yeah. Great. So as I was saying, thank you very much, Joyce, for that talk. I'm sure it'll generate a lot of questions. One or two have come in about sort of availability, whether they're free. My understanding is that many of them are not, but given your sort of unique position, which I think you have in your understanding of this field, if somebody was to come to you, perhaps one of your students or a colleague, and was saying, look, I think there might be value in using an app, which one or which sort would you recommend, if any, and what would be your advice to them?
Yeah, I think for young people who are not trying to get pregnant and not using it as a form of contraception, just solely using it as a period tracker, I think most of the common downloaded apps have their place. it's just worrying that they're telling young girls that they are ovulating. And unfortunately, how all my research in this area started was that my master's students had told me that these apps were telling them that they've ovulated. And I said, how can it tell you that by just looking at dates? And they do. They unfortunately, almost all of them do tell them that. And some of the app companies have contacted me, and they've said, look, we're aware that we probably shouldn't be doing this, but they're not going to undo it. Trying to explain to the public why for decades they've told them when they ovulate and now they're not going to tell them. I think it's just too much of a difficult story. And my worry is the flip side of those trying to get pregnant. I know that there are people who think they've ovulated on day 14 and then have unprotected sex. And as I said, that the majority of cycles we looked at, ovulation was much closer to day 16, 17. So that's really worrying. So I'm doing a lot of school talks, and I'm going around telling all of them, please don't think you're not going to be fertile and could get pregnant when your app tells you you ovulated. So please ignore that information. I think women that are using it as a fertility app, they could still miss their fertile window. And I think it could, we've been talking about stress in the other presentations, and I think it could lead to even more stress. I think if you're going to use one for fertility, definitely use one that is at least doing basal body temperature or luteinizing hormone. But I wouldn't recommend any particular one.
That's very clear and very helpful. Thank you very much. So we've come to the end of the presentations. We now enter a period where we can reflect on those and perhaps some of the larger issues around this growing area. And I'll hand back to Jacky, who will take us into that discussion. Thank you very much.
Thank you. I wonder if our colleague Eri has arrived. Not sure.
Yeah, I'm here.
Ah, nice to see you, Eri.
Nice
Welcome,
you.
welcome. We gave your introduction earlier, but it's just nice to see that you've arrived and that you can be part of the panel. I'm sure it's very early in Japan now.
Yeah,
probably
it's
too early.
yeah, but it's already 5 a.m. So
Okay.
I can be here.
Thank you very much for that very early waking up time for you. Okay, so what we're going to do now is we're going to have the panel discussion, and we've heard about quite a mixed bag of apps, but all of them, of course, serve the function of providing some kind of information or support around fertility, reproduction, how to take care of your reproductive health. So it would be good now if we have the panel on to start the discussion maybe with people's views of what it means that we now have those apps and that people feel they need those apps. What does that say about how people want to manage their reproductive lives? So we're going to have a discussion now about that, and then we're going to start taking questions from the audience. Do we get everyone on view for this? Yes, everyone's kind of coming on. Nice to see everybody. So Joyce, did you want to start off with that? What do you think it says about people's reproductive life, how they want to manage their reproductive lives?
Yeah, I think times are changing for us oldies that have been around since the 80s. My students are just finishing their taught modules this week, and yesterday we talked about the future of reproduction. I had a brilliant discussion with them, and they one of them said how we look at we talked about apps, and they said we're not worried about app companies having our data, and we're not worried about we don't have concerns about doing preconception expanded carrier screening, for example. She said it in a much more subtle way, but basically that how she felt that how younger people were thinking about their reproductive health and their reproduction was different to how we were thinking about it. So we're just about to submit a paper actually from our survey, and in our survey as well, the women that filled it in that use period tracker apps were not worried about data breaches, etc. So I think younger people that come now to get pregnant are going to be embracing all of this tech in a much bigger way, even things like genome editing and all those sorts of things, than I think we're very cautious, and I don't think they'll be so cautious. I think we've got to keep up with understanding how they think about it.
Okay, so things are changing. Alison?
Yeah, when you mentioned that, Professor Harper, in my mind, if there was a period tracking app or anything like that, I would say, yeah, I'm going to put it on my information. I'll put in my birthday. I'll put in my last name. Why not? Nothing's going to happen. And that's just my mindset. So I'm 22. So you guys do know my age. And that is who my coworkers, my fellow students, that's just how it is right now. And I think that when it comes to, talking about, are apps a good thing? Are apps going to replace people? Are apps going to kind of take over the medical field and how treatment is distributed? I don't think we look at it that it's a bad thing. I think we look at it as it's a way to increase access for everyone across the globe, and not as it's going to replace someone's job, because frequently it won't. It's just going to be an additional resource. But that's just my outlook on it, and coming from, my friends and my coworkers that kind of all have the similar perspective as I do.
It's kind of augmented reality in a way, isn't it? It's additional information. I wonder if anyone else has anything to say on that topic. Maybe Bonnie, from the perspective of a clinician. I'm sure you see young people with those kinds of ideas, and you're young yourself.
Yeah, I was going to say that being a clinician and seeing women who have infertility and recurrent miscarriage in clinic, practically everyone uses a period tracking app. So when we ask them their last menstrual period, they say, oh, wait, I'll get my app out. So I don't think that was the way it was done like a few generations or last generation, whereas now everyone is using these apps. And I think it's really important, like Professor Harper said, is to validate these apps and make sure that we're not sort of misleading patients and misguiding them, and making sure, as clinicians, we sort of direct them to what's evidence-based and that's going to lead to the best clinical outcomes for them.
The thing that's interesting is what Joyce's paper pointed out, is that we've been misguided in what we've been telling people for the last 40 years on day 14. So, misleading information is kind of part of how things are managed.
We never expected that. That's not what I expected from the paper. I was. Yeah,
it's very interesting. So basically these apps are there, and it sounds from what you're saying is that people are in control of the app and not the app in control of people. People aren't being led by these apps in one direction or another. Do you think that's true, even when you think about the commercial purposes behind that, or motives potentially?
And yet, if you look at some of the data on use, and especially if you charge for apps, I mean, there's this big divide between free apps and apps one pays for. And I've kind of learned this the hard way. People will download apps, but how much will they actually use them? And I mean, how would you explain with a Meta Emo app that use dropped off significantly after egg retrieval, which is the most anxiety-provoking time? Why weren't they using the coping suggestions parts of it? When Ferticom was free for about 3 years and it was sponsored by Ferring, we expected everyone going through infertility to download it. It was a free app, and a lot of people didn't. So there's a leap between.
I wonder whether that might have been, having been involved in that Jacky's paper and Bonnie's paper, because it had this combined effect use. It was both clinical, reminding people to take drugs and things like that. It might have been an artifact of that, in the sense that, I don't know, Jacky, was it, or Bonnie, was it possible to differentiate use for for clinical things and for psychological support? Because I wonder if the psychological support might have continued, but the drop-off was due to other, I don't know, that's just a
Well, they, on average with the MedEmo, so, you know, for people who aren't familiar with this app, it basically has a medical management component. That's the Medi bit, where you get information about what drug dosage you should take in a stimulated cycle. And the emo is the bit that is the emotional management and allows you to monitor your reactions and so on. So people did use the app. There was drop off afterwards because, well, this is based on other data about daily monitoring. There's always drop off after day 8 because people start spotting and they think they're not pregnant and they want to have nothing to do with anything that has to do with the clinic at that stage. So I think there's there's a high percentage that relates to that. But there could be other things as well. You know, people just, you know, they're stressed. They don't want to monitor their emotions. They don't want to know they're stressed. Could be.
I was wondering if I could come in with
I was going to ask Ali 2.0. You know, is there, you know, for example, for me, if I had, I don't know, some condition and I knew there was an app that would provide me all the information and support and really medically valid information that my physician recommended, I think I'd be all over it. You know, Ali 2.0, do you think your generation would be less likely to endorse that or to actually use it on a day-to-day basis?
It's kind of a hard question to answer because I think it depends on what they need it for. If it's something that was very pertinent to their everyday life, then yes, I think people would use it. But if it's something kind of in the background that, you know, you see a dermatologist every year or something like that, and you have this information on your phone that can talk about that, no, that wouldn't be something that would have a lot of uptake until you're actually coming to that annual appointment or you notice something that needs to be addressed. But otherwise, I don't think so. But with infertility or fertility treatment, something that for a ton of women is a major, major thing in their life, I do think that people would use it. If it works.
You know, the reason I'm sorry I was distracted, I was talking to my new boss about a new online program they're interested in. And I see personally a big disconnect from all the research that I and others have done showing how distressed our patient population is, how much they need resources, they're craving information, they're craving coping suggestions, they're craving stress management, they really want lifestyle education. And they say all this, and every study has shown that. And then you come up with these pretty easily accessible entities which will provide that to them. And you can show them data like, yeah, this stuff works, and there's no uptake. Mm-hmm. So why is there a disconnect?
How different is that from them? We have in the UK mandatory offer of counseling, and 15% of people use it, 20%. Right. I don't know. What do the others think? What's your experience from a kind of maybe more clinical kind of perspective?
Also, when I was at Boston IVF, when COVID hit and everything switched to Zoom, our requests for counseling tripled. So I don't know how much of that was people were frantically anxious and upset at the beginning of the pandemic, and how much of it is, wow, it's so easy to see a therapist via Zoom. And it's still very high. It's very hard to find a mental health professional in the US right now who is experienced in the REI field, who has access to take on new patients, because doing therapy remotely is so much easier for patients, but an app is even easier. You don't have to schedule an appointment to use an app.
Well, that's going to be the next research. Nick, you were going to say something?
Yeah, I mean, one of the questions that came in actually during your talk, Ali, was, compare how do apps compare with an online counselor? And I think there's a broader question there, and perhaps a concern that some people might have is that apps are seen as a means of sort of a low-cost palming off patients with a second-rate, cheap-to-offer care. And do you think that's a realistic fear, or do you think, again, it could be something that's generational, that there may be a generation who actually may feel more comfortable interacting with a mobile phone than with an individual, and another one the other way around? Is there any evidence?
Joyce is nodding.
I think I've got a house full of teenagers, you know, they don't phone, they don't phone each other anymore. Everything's, you know, a chat on a, you know, on the phone, no chat box, I suppose. So yeah, I think they're really changing. I think young people are I don't know, I'm just feeling really old, but they just seem so different with the tech now, that we've got to keep up with it, you know. So for me, I can't understand why. I went through 7 years of IVF, and I would really want to see a counsellor face to face. You know, I think Zoom to me is, I can't understand how anyone gets. I think you miss so much. But then
but actually, Joyce,
no,
you
I'm
don't.
old. Yeah, and I'm old. Young people don't see it like that. Young people would be, younger people than me, which would be really happy to, you know, do things.
No, but Joyce, I disagree, because I've literally been doing therapy full time for 27 months now, and every single session has been via Zoom. And I mean, the research shows that Zoom therapy is just as effective as in-person therapy. My patients love it, and it's very hard to get rid of a patient because she loves it. I hate it. It's really hard to do therapy for 45 minutes just on a Zoom call, but I don't think we're ever going to get patients to come back into the office for therapy, because, you know, if you're a lawyer and you have to get in your car and drive half an hour and find a parking space and see your therapist and get, you know, versus at your lunch hour seeing your therapist for 45 minutes, it's a no-brainer. You know, most professions, people can't just up and take 3 hours away from the middle of a workday. So I don't think we're ever going to get away. But the issue is, even with Zoom therapy, as Jacky just said, the vast majority of patients or individuals, there's no uptake. So there is a disconnect. These patients are miserably anxious and depressed. And we haven't quite figured out yet what is the most effective way to meet their needs.
I wonder if that might not only vary with age, but also with societies. And that, you know, Eri's joining us from Japan, where there may be different cultural norms in that regard. And I just wonder, Eri, whether, you know, you did a very interesting randomized controlled trial looking at a chatbot, and they have a very mixed, shall we say, image. I would say sometimes as being over automated and you can't trust them. And I'm just wondering, you know, in general, in the context in which you work, are these sort of automated support systems widely accepted, or is there a general skepticism about them?
Oh, during inside my research, there are a huge variety of comments. Some people accept chatbot very friendly, and they like that, and interesting and very easy to talk about such sensitive topics. But other people say that it's very impersonal and cold, and they don't like chatbot. So I think people have very different opinions toward chatbot and automatic conversation. It's a future research question to in-depth qualitative research, I think.
Yeah. So amongst your colleagues and patients, are apps popular?
I'm not a clinician, but most people use menstruation track apps in patients and in general population. Yes, but I'm not sure automatic conversation is not, I think it's not popular yet.
Okay. Jacky, do you think it'd be interesting to ask the panel about, to look into the future and sort of how's the world going to look in 10 years' time?
Yeah. Yes. How is the world going to look in 10 years' time in terms of reproduction, do you mean? Or
in Appsville.
In Appsville.
Yes.
Where are we going?
Are we just going to be sitting in a box, just doing everything with apps and reproduction? And,
That's the exact question I asked my students yesterday in the close of the session. I said, what will happen in 10 years? That's the exact question. Can I just go back one stage to what Alice said about counselling online? It just made me think a little bit about you know, vinyl versus CD versus streaming music. You know, I'm from a generation where we always want to talk to somebody, and we want to be face to face, and we want to go to a conference and talk to an audience and meet people. But yeah, we're like the vinyl music. But then the convenience that, Alice, when you were saying, you know, who wants to get in their car and go here, the convenience of doing things online obviously is really attractive to some people. And it's just like, you know, streaming music, you know, it doesn't sound anywhere near as good as vinyl. And I, you know, I can imagine the counselling. I personally can't see that it, you know, you said you don't like doing it because you miss that physical contact, you miss the energy of somebody. So it is like
I have not had a single patient in the last 27 months ask to see me in person.
Yeah, it's interesting.
And I'm seeing patients right now ages 16 to 55, I'm guessing, and all of them want to keep it remote.
Yeah, and then going on to the future, I'm just bringing up what my students said yesterday, because I asked them in a survey, and yeah, I mean, they talk about what's the next 12 years. So we talked a lot about transhumanism. We sort of go that far about how we will alter ourselves much more. And we talked about stem cells and making artificial gametes from stem cells. One of my students was actually absolutely convinced that once we have an artificial womb, no woman would want to carry a child. I didn't agree. I know I didn't agree. I don't agree. But I just think, listening to what we've been saying today, things change. And I don't know whether, I think Aldous Huxley was right in Brave New World. I think people won't, I really think that we won't carry children at some point.
Oh, I completely disagree. There are a lot of women who like being pregnant, and there's this whole world of epigenetics showing the influence of the uterine environment. But I want to ask Allie 2.0 a question. She has expressed interest in, she plans to go to medical school and become a physician, but she has expressed a pretty sincere interest in becoming a reproductive endocrinologist. So I would ask you, Allie, if you go to medical school next year, so let's say 10 years from now, you are going to be an REI. How would you like to see this technology be made available to your patients?
And for Bonnie as well, I think. Go on, Alison.
I actually wrote that as a note at the beginning. I would like to see it as a part of mainstream care. When they come in to see me, I give them this information, and I don't want to say homework, but it should, I think that if it works for them, then that's fantastic. But my job will be to at least give them that opportunity to do that, to use the apps. And have it just be a part of, they take a medication, they log into their app every day, and it becomes a part of their daily routine. And I think that's a big thing of potentially why the uptake is so small of just regular apps, because there's no schedule as opposed to logging on to a counseling session. You have it in your calendar and it's this time of day. I think in the future, these apps will become just like taking a medication in the morning and taking a medication at night.
And
it's interesting.
So,
sorry.
Yeah, so I would add that there's probably no substitute for individualized healthcare and personal interaction and the social element of seeing a healthcare professional. So I think our job as clinicians is to take what's available, use it to our and our patients' advantage, and provide the best user experience to improve health outcomes. Yeah, so I think it's about guiding patients and letting them know what apps are available, because I think not everyone likes to use apps, and it would depend on the patient. But I do see the huge value in having them sort of in between seeing a healthcare professional. There's so many opportunities to help optimize things such as medication compliance, psychological well-being, lifestyle, but it would never replace that human interaction, I don't think.
And just like taking a medication, sometimes medications don't work for people initially, and that's can be the job of the clinician to, they recommend an app, it doesn't work for them, then they work together with the patient to find the right app or counseling or anything web-based session that is correct for them. And that could be a long process to find what works, just like medication.
Yeah, and I would echo that, because we've already talked about, like, a lot of people drop out from using the apps, and compliance, even within the Smarter Pregnancy lifestyle coaching within my study, a quarter of patients at 24 weeks didn't use it. And it's really important to find out, why did those women not use it? Was it, you know, the interface, the usability? And it's really important to work with, you know, these patients to know what they would like, to develop the app in a way that's user-friendly.
This is something that someone asked, and in fact, you know, are we asking people the right questions, and are we asking them what they want in an app? You know, in a way, what is the genesis of apps? And I guess the Mediate and many other apps are based on co-production with people experiencing the problems we're trying to solve, but not all apps are done that way. But it does suggest that going forward, you know, you're suggesting a really close relationship between the physicians and the patients in selecting apps. But is it really the job of the physician to help find apps? Or are we going to need like a new cadre of workforce called the app consultant that's going to be attached to the clinic and is going to be able to do that kind of, you know, have that kind of interaction?
How do physicians choose medications? I mean, if there is a variety of different gonadotropins, for example, physicians tend to prescribe one they are comfortable with. Maybe that will be the same with apps.
Well, if that's the case, we'll have to train them.
Well, I think maybe what you need to do is develop an app that helps clinicians.
I'll get on that.
Well, I think even with medications, there's the FDA and MHRA that approve the use of these medications, whereas with apps at the moment, there's nothing regulatory.
Idea whether there could be a sort of a quality mark on some of these. I don't know, Joyce, if that's something that you thought about.
Yeah, we have. We put it in a few of the papers. And from dipping in this sort of corporate world of femtech, almost everyone I've come across that's made any of these apps have not been a reproductive scientist or a clinician. They've normally been an app designer. There was I was on a UCL Women in Femtech conference a few weeks ago, and they had an hour session with the woman who's made the first online fertility clinic. And you know, when she told her story, she's a tech person. She knew nothing about, I can't remember what they're called. You might know what they're called. And then the next person she got to join the company was a quality manager that had worked in a UK fertility clinic. Again, not a clinician. I was like, wow. You know, so I'm trying to listen to more of these people present and, you know, try and figure it out. And I just wrote in the chat as well, in the Q&A, a lot of the influencers in fertility are patients. They're not health professionals. And, you know, those people now that are going into companies and things and talking about fertility are often patients that have been through it. And maybe that's fine, but I don't know how that all works out. They're the influencers. So
you have to apply the science. And by the way, just an FYI, I think we're about to sign a contract for a company to take Ferticom, which is for women, to the FDA and have it hopefully registered as a device.
Yeah, that's what they're doing now.
Yeah.
The thing that surprises me is I think, you know, my parents were, when they had their first child, were 19, I think, or something like that. You know, they just went, ambled off into the woods of the Canadian countryside and had a baby. And, you know, when you think now how complicated it is, the whole family planning, the whole monitoring, the whole support, the whole information needs and so on, does it really need to be that complicated? Inclusive now, you know, things like the wearables that give you everything about whether you've slept or not and how that affects your fertility. I mean, is this all really needed, or is it just the industry making us think we need it?
Well, maybe it's needed for 15% of people who don't get pregnant after a year.
But is it, they're not the only ones using all of these things, right?
Yeah,
we have all the
we
preconceptions.
shouldn't medicalize trying.
Hmm?
We shouldn't medicalize trying.
Medicalizing everything. We are seriously technologically and medicalizing everything, Jacky. So you're totally right.
Yeah, so that's the word I was looking, like technolizing, but I don't know what the word is. For that.
No, let's make
Nick,
it up.
is the word Smith here? What's the word for
The thing
when?
that comes to mind is that we're beginning to sort of divide along generational lines.
Yeah, I hate to say
There
that,
is that as well, but
Yeah.
I mean, it's not necessarily a bad thing. This is with the story I told you yesterday. If I say to my stepson, you know, did you sleep well? He looks at his watch to, you know, for him, the watch helps him to make decisions about that, to answer the question. You know, in the future, it'll be, you know, do you want to have sex? Just a second, I'll look at my watch. With my like desire-o-meter or something.
I've yet to see, you know, if you ask a man how often when he last ejaculated, I haven't seen them consulting an app yet. So
Yeah, not yet. Yeah.
Just wait.
Just giving someone an idea.
Yeah. There's an app control, you know, a kind of control on the sperm production or something.
I kind of would suspect that most men remember when they last ejaculated.
yeah, they possibly do. Right? You need to. It's an interesting study.
Yeah.
But I think moving back onto, shall we say, the core ground, I think what's been really helpful is to understand the different voices in this. And there is a definite feeling, I think, amongst the group, and I guess amongst those joining us, that apps are here to stay and the world is adjusting to them. We see that through the way in which the younger generation seem extremely relaxed about them compared with some of us older ones who are perhaps a little bit more concerned about what's being lost. But part of that might be because the younger generation haven't experienced the option of, you know, good old face-to-face consultations and, you know, and less control. And I just wonder, Alison and Bonnie, I suppose we probably ought to be drawing it to a close, and Eri as well. You know, looking to, do you think that there is an awareness amongst younger people who are perhaps adapting to apps better what the alternative might be, or do you think that this is just what they think the world is like now? Bonnie, would you have some thoughts to kick things off?
I think part of it is this generation is the new norm to have, you know, meetings via Zoom and Teams. So there are less social interactions now. And yeah, we practically have an app for everything without thinking, you know, data protection and all of that sort of stuff. But yeah, I think it's maybe that what we're used to as well and what we've been exposed to in our generation and our time. Indeed. I don't know if
Eri and Alison, would you agree with that?
I do feel like it is a norm, and web-based apps are becoming even more of a norm. And you got me thinking about 10 years down the road, and I think they're going to be even more of a norm for even more things than they already are there for. So yes, I think that they're here to stay, and it's going to be a part of every aspect of everyone's life.
They may not be on phones. I mean, now we have rings and things we can wear and everything else. You may not even have to go to your phone to get this information.
We were discussing the other day, why do we still call it a phone when no one phones anybody? That's the least
That's how old I
Least thing
am.
it's used for. It needs another word. Why is it still called a phone?
Eri, what were you going to say?
Yeah, I agree with you, you all. Yeah, we cannot live without apps or smartphones. So the norm is very much changing.
Yeah. Okay, well, I think, Jacky, I think that's probably a good point to draw the discussion to a close. Would you agree? I mean, I think I'd like to thank we've had a lot of questions in, and it's always impossible to articulate them all. But what I would say is that they've been very helpful in shaping the discussion we've just had. So thank you, everyone, for sending them in. And before we close, there's a few people to thank for this. Of course, our speakers, my co-host Jacky, Alice Domar, Alison Meyers, Bonnie Ng, Eri Maeda, and Joyce Harper have all taken time and effort out, not only to submit their paper to an excellent journal and to succeed in having it accepted, but then to come and share that more widely through the terrific i3 platform. And we're grateful to you all for joining. And to talk about the i3, there's been quite a few people from i3 helping us this evening with this, and I'd like to name a few. Giles Palmer, who's been very helpful, Jacques Cohen, Peter Nagy, Vicky Almela, Marianne Savetes, and Thomas Elliott helping us with the technology. So it's been a big group production, and there's still no app for that. So we all still need people to put these wonderful events together. So again, thank you for joining us, and I'll hand over to Jacky to close the session.
Yes, well, again, thank you, everyone, for joining us, the audience, for your very stimulating questions. Hopefully, we've addressed them, not necessarily with the direct questions, but roundabouts, and given you plenty of things to think about. And if you enjoyed this, you may even enjoy more the next RBMO live episode, which is on the 6th of September. And it will be showcasing the latest developments, hot topics, and papers from a section of the journal. Before then, you do have the opportunity to come back to i3 for the topic, a double webinar at different time zones on the 21st and 22nd of June. It's called Legacy Part 1 and 2, which will be looking at recruitment training, talent management, and succession planning for clinical embryologists. So for all of you interested in that, that would be brilliant if you could attend. You just have to go to the website to find out more. When we close this meeting, a feedback form is going to pop up on your screens. And I hope that all of you can fill out the feedback form and give us an impression of your experience today. And I think are you able to access this session later? I believe so. Yes, the recording I think is available at a later time, because sometimes people can't make the session today. I think you just need to go to the i3 website to find out that information. I think I've said everything I need to say, Nick, is that right?
That is, yes, thank you, Jacky.
Yeah. So the session is recorded and will be available on the i3 website. And we have a nice comment to end on, which is great that it was so international. And it was an international panel and international in our global audience. So thank you very much and see you again.
Thanks, Jacky. Thanks, Nick. Bye.
Bye.
Bye, everyone.